So now we are back. Sorry for the delay. Basically, we have to provide the recordings of this lecture to GIAN. And for that, we need to store the data in the computer. And that took plenty of time. That is why this session got delayed. That was some sort of technical issue with us. We will try to address this issue from tomorrow onwards. We'll use multiple systems so that we can save this precious time. But yes, we are back. And I hope that the participants are ready with their questions. And I think Professor Miwako Hosoda is already here. So she is ready to respond to the questions and we will have a discussion. So please, participants, you are requested to ask the questions and Professor Hosoda will respond to those things. And if required, I will also respond to some of those things. Yes, we can start the discussion.
Hello. I'm very happy to have your comment on the question. So as a basic knowledge, did you already get the course or lecture of medical sociology or sociology of health?
See, ma'am, this course is actually using an open platform and not every individual who has joined this course is from sociology itself. Just a minute, just a second.
Yeah, I have a question from the chat box. So the Srija, he or she asked me what is the healthcare system in Japan. So good question. I'm going to talk about this one, the Japanese healthcare system. Or something. But I'd like to talk briefly about the Japanese healthcare system. So Japanese healthcare system is universal healthcare coverage. It starts from 1961. Actually, we have already 70 years history of the healthcare coverage. So it was just after the World War II. And the American occupied the body implement the universal healthcare coverage. So it is not a Japanese origin, but even though it was forced to implement the universal healthcare coverage, it was really beneficial for us. Before World War II, the Japanese healthcare, Japanese life expectancy is only 44 years. And after the World War II, it's almost the less 60. However, after the implementation of the universal healthcare coverage, the life expectancy grew more than 80. Of course, it is not only because of the life healthcare coverage or medical, but also the many reasons like the hygiene system or people's nutrition and lifestyle. And there are so many reasons. However, I'm confident there are the certain percentage of the reason why the Japanese is healthier. It is from the universal healthcare coverage. Are there another question about the Nordic healthcare? Yeah, so this one, the next question is, yeah, I introduced that the Nordic health system, but this kind of the universal healthcare it makes long queue because this is kind of the demand and supply issues. If there are enough healthcare service and healthcare professionals and the healthcare budget, this kind of things doesn't happen. However, the limited amount of healthcare makes this inconvenience. So, like Canada and Australia and of course the UK, they have the universal healthcare coverage. However, many of the people have private insurance to get quick service. So how should we do? In this case, it is very close to the American system. The people who get money or who are affordable to buy the good health insurance can access the good health care. It is not equal, even the it's not inclusive. So the solution, maybe you can imagine, to get much more resource to the healthcare, like the national budget and the healthcare professionals, and they make expenditure to get the cost of healthcare get lower and distribute or to be able to distribute everybody. So did I answer the question? Thank you. Yeah, also, yeah.
So, participants, do you have any other question? Because Professor Miwako Hosoda is here to respond to your questions. If you do not have any question, then
yeah, may I have a question? So yes, in India, I heard you are trying to implement the universal health care in India.
Right.
Still, it is not covered all the people in the nation. So how do they get health care? Do you have a private healthcare insurance, or do you pay for the full expense of the healthcare service?
Okay, we have one lecture scheduled on this topic, that is health coverage, right? But as of now, I would like to respond to your question. In India, basically, we had a latest national health policy, that is a health policy 2017, and it focused a lot on universal health coverage. But basically, this we need some kind of understanding of the political system also. We are a federal government. Our government is basically federal in nature. So we have the national government, that is the union government, and the state government. And health issue is something which is basically there which is taken care by the central government as well as the state government. So on the one hand, we have the state governments which have their own specific model of health coverage. For example, in India, out of all the states, we often hear and we know that statistically, Kerala is having the best health indicators comparable to any developed country of the world, right? So infant mortality is very low there. Life expectancy is comparable to any other developed country. And on the other hand, we have states situated in the northern part, like our state where we are living as of now, Uttar Pradesh, Bihar, Jharkhand, Chhattisgarh, they are having poor indicators. So there is issues related to the state government and the kind of program that the state governments are having. So keeping aside that, the central or the union government has introduced universal health coverage model in 3-4 different layers, right? First of all, if you try to understand what kind of health coverage policy we are having. So we are having multiple health coverage policies. On the one side, we have the state-sponsored health coverage things, which is basically applicable to the government employees and the formal sector. On the other hand, we have the insurance model of health coverage, which is basically applicable to all citizens who have the affordability related to that. Basically, people go for health insurance. So there is a combination of public and private. These are two things which are very visible at the overview level or at a broader level. Then there are other things, like some of the state governments have the social insurance model. That means the state governments basically pay the substantial part of that, and they take a symbolic or a token amount from the citizens also, so that it should be a participatory model. So many of the states are having those participatory model, which is generally known as a social health insurance model. So these three, the health coverage is taking care of the health needs of people at these 3 levels. Then there are few interesting things. For example, vaccination. The National Health Policy to 2017 talks about universal health coverage in terms of vaccination. That means all citizens of India are entitled for the necessary basic 4 vaccines free of cost. And that is provided by the government hospital system. So this is another intervention in terms of health coverage. And then if we take into consideration the public health issues related to that, then recently we had the COVID pandemic, and during that, basically the vaccination became a very important thing. And then the present national government basically provided free of cost vaccines to all people. So there are multiple things which are operating. We cannot say that we are having one specific model or that specific model. So we can summarize the whole thing by saying that we have the public-private model of universal health coverage. On the one side, the government is trying to reimburse the expenditure basically incurred on healthcare. And on the other side, there are people who can afford to pay the health insurance. So they are also following that. And at the third level, we are having a robust, I won't say, but basically functionally or operative kind of public health system also. And many of the government hospitals are providing free of cost healthcare. Right. For example, in our university, that is Aligarh Muslim University, we have a very renowned hospital, and here the patients are getting healthcare facility free of cost, right? Or a minimum user charge. Minimum user charge is there. So even in terms of user charges, you can see some kind of variation. Some of the government institutions are not charging anything in terms of user charges, or some of the government hospitals are basically taking little bit of user charges also. So even within the public health model, there are different systems operating. Then I can say a bit about Kerala. I visited that state just to understand the kind of public health system they are having. And they are having a very robust. See, it is, I mean, maybe people coming from other states won't believe this, but they have a very robust primary healthcare system. and the infrastructure part, the logistic part of that primary healthcare system is much better than the hospital system in some, the tertiary level health system in some of the other states. They are giving the patients an option to select whether they want to get treated allopathic system of medicine or a traditional Indian system of medicine. That is also there. So I can conclude this question by making this observation that we are having as of now multiple models. But yes, this is also true that the cost of health expenditure is increasing exponentially in India. That is also a reality. And basically, we are yet to develop a system where this cost of healthcare could get minimized for people at large. And that is why we have the problem related to accessibility and affordability. As of now, perhaps the government is working on the availability model. Once this availability model is settled, then perhaps we'll start more rigorously on the accessibility and affordability model. So this is how I can make a small observation on this large topic.
Thank you very much. Yeah, it is really informative. I found someone raised their hand. He stopped.
Please shout. Don't shout. Participants are supposed to not to shout.
Online course ஏதாச்சும் ஒரு கோர்ஸ் முடிச்சு ஆகணும் அப்படிங்கறாங்க NPTEL மாதிரி.
Yes, is there any other question from the participants?
My question is,
yes,
in the last lecture where we had three types: liberal, corporatist, and social democratic. Where would we place India in these three? One of these three categories, typologies.
You just your own answer, please.
Sir, I'm think because corporatist and conservative is in the middle. We are neither completely free market, neither is our decommodification maximal, so probably corporatist.
Actually, it is totally dependent on the country and the people. So I cannot say which one is the best and the better. It is the people's selection and the national income, or is very different in each country, and people's belief is also different. But at least what I can say is to make the equality and equity of the society, and the tax-based healthcare system is the best. However, as previously I mentioned, the budget is limited of all countries. So ideal type and the reality is different. However, so people has to discuss what point is they can compromise. So yeah, that is my answer.
I can add something here. Basically, who raised this question? Can you speak?
Sir, Tej, sir. Tej.
Okay, Tej. Okay. Can you repeat the question? Because I will help you to understand the answer yourself. Yes, can you repeat the question?
Sir, what I was asking is, in the different types of typologies that were described, where would we place India?
What are those three typologies?
Sir, social democratic Nordic type, which is universalistic. Then we have the conservative corporatist type and the liberal or residual type.
See, if we go by the preamble of the Constitution of India, how India is defined there? India is a socialist country, right?
Yes, yes, sir.
So the preamble defines India as a socialist country, and responding to the earlier question, I had stated, right, that in India, we have a robust public health system, which is basically performing. Many of the states are performing very well in terms of providing the basic health facilities, right? No matter which part of the country you are, you can always see a very good functional public health system, right? So that part basically takes care of the socialistic model that we can understand. But simultaneously, we also have a fast growing private healthcare system. That gives you an idea that that is the corporate system of basically health, right? That means we are basically a mix of both the things. And this is how basically India is defined, a mixed economy where there is some kind of input from the socialistic pattern and simultaneously some kind of from a capitalist system. So primarily we are a mixed kind of country where we provide some space for the public health system, that is the socialist pattern, and at the same time we have space for the private system. And as of today, we are talking about privatization of healthcare in India. You might have heard the term privatization of healthcare. What does it indicate? It suggests that the government funding on health is gradually declining or decreasing, and basically the exposure to the private sector is gradually increasing, right? I have one lecture on universal health coverage, and that day we will discuss these things at length, because basically Professor Miwako knows a lot about her own country. She knows a lot about the Western countries where basically she has conducted the study. So primarily, you can focus on those aspects in today's discussion. We'll come to Indian context when I'll talk about the Indian scenario. Is this okay?
Yes, sir.
Right. So basically, this is a big opportunity to understand the Western model. And brilliantly, she has elaborated some of the things. I would like to come back to that point again, that I was talking about at the time of the closure of the lecture, that equality, equity, and inclusion model of health. There are participants coming from different backgrounds. Some of them are coming from the engineering background. Some of them are coming from the medical background. Some of them are coming from the social sciences background. They might not be understanding very well these three terms. I think I was expecting that someone could raise a question on this. If you're not raising a question, I'm going to raise a question on this. Professor Miwako, can you help our students who are not necessarily from sociology background to understand these three things: equity, equality, and inclusion? Because that is going to help them a lot. Would you like to respond, Professor Miwako?
Yes. Actually, the SPN understands model is the three type of the social welfare state is among the social capitalist country. So they don't mesh, they are not covered the socialist country yet, but you can have some reference from the categorization. So yeah, maybe I hope it will help you to consider how the healthcare system and the social welfare system is developing in your country. Thank you.
Is there any participant who is not understanding the difference between equality and equity? Because these are very tricky terms. If you are not understanding these terms, then basically you are not understanding the way the political economy is basically operating. Do you understand equality, the difference between equality and equity? Participants can respond. I'm not getting any response from anybody. Do you want me to explain this a bit?
Sir, there was
Maybe.
probably some problem in the connection for some time. I don't know.
Oh, there's some internet connection
No, but
trouble.
as of now, we are all connected, I think. No, but I'm asking this question again, that is there any issue related to understanding that the health models, primarily these models that we are talking about, that Professor Miwako was talking about, are based on those basic concepts, basically. The equality concept, the equity concept, the inclusion concept, right? So do you understand these terms? Now that is the basic question.
So may I request to kindly repeat that difference between inclusion and equity?
Yes. Now, this is a very specific question. Professor Miwako, can you respond to this question? Difference between equality and inclusion and equity.
Okay, so maybe it's better to see the previous slide. And can I ask you, so the student and participant, they already get my slide, or Professor Akram, so you will give them the slide afterward?
Right. Yeah, I have shared the slides. Right. Okay. Let me try to answer. Let me try to answer this question. See, what is equity? Equity. Let us discuss these three concepts. If you can understand these three concepts today, then that will be very helpful. How do we define equality? Equality means providing all people equal opportunities. Can you remember the last slide that Professor Miwako was having? Right. Equality means, say, I'm giving you one example. If there is a mother and there is a daughter, the mother is, say, 40 years old and the daughter is, say, 2 years old, and both are hungry and both need food, and there is only one bread available. We are talking about an extreme starvation situation. Right. So let me first explain the example that I'm giving, then I will respond to this one also. So if there is only one bread available and there is a mother who is 40 years old and there is a baby who is 2 years old, then how can we distribute that one single bread among these two people? So there can be one approach, that equality means you can halve the bread and give one piece to the mother and the other piece to the child. The equal distribution of the resources. But will it serve the purpose? I think all of us can understand that no, it will not serve the purpose. Why? Because if the baby is under starvation, then she may collapse very soon. The mother can survive for a longer period of time. That means who is in need of that single piece of bread more? The child is in need of that single piece of bread. So equality says that distribute that slice of bread equally among both the stakeholders, and equity says that whosoever is more needful, the piece of bread should go to that person, right? This is the difference between equality and equity. And then inclusion talks about a system where if this situation should not come, that two people should be left with this much of a starvation kind of thing. That means we are not dealing with these situations in particular, we are talking about the system in general, that there should be a distribution system where all needful and stakeholders should get the optimum amount of fulfillment of the needs. That will be the inclusion kind of thing. And this picture is also showing you this kind of thing in a different way. Equality, you can see a baby, then a child and a grown-up person. They are all standing on same size of platform. But despite remaining there on that platform, the child is unable to see the stadium. This is equality. Equity means the child basically needs more support. So there are two platforms. The father or the mother or the adult person doesn't need. So he is not having any platform. That means the needs of all the three persons are getting fulfilled. This is equity. Now, in inclusion, see, there is a huge difference. The barriers have been removed from the boundaries. Inclusion says that we need to develop a system where there should not be any artificial boundary or barrier. So if we have an inclusive system, we don't need these kinds of platforms which basically serve the purpose of the individuals. So that is the difference between equity and inclusion. Equity is definitely one right way of moving towards inclusion. And when we are talking about inclusion, we also need to understand exclusion. Basically, when a system operates in such a way that certain people or certain category of people get move out of the system, right? Get discriminated in such a way that they cannot fulfill their needs or their requirements within the system, then that creates a kind of exclusion. Now, there are different types of and levels of exclusion, right? I hope we understand that. Sometimes we talk about stratification, sometimes we talk about other kinds of divisions like caste, like class, right? Or racial sort of thing. All these things are there, which create some kind of exclusion. Inclusion helps in improving the system so that the needs and requirements of all people should get fulfilled. Now, the next question that may come to your mind, that how these principles, basically equality, equity, or inclusion, are getting addressed in the healthcare model. That would be the basic question. Basically, when we are talking about equality, that means all persons should have some kind of equal access to the healthcare system. See, there is a healthcare system or a hospital situated in your neighborhood, but the cost of care is so high there that even if it is available there, you have an equal access, but you do not have the affordability. You cannot pay the fee there. That means availability of that system is not making any difference in your life. Why? Because even if the system is there, this is not affordable for you. So that is a kind of application of equality, equal access to all. Equity means that those who are poor, they will get some kind of subsidy, they will get some kind of reimbursement kind of thing, subsidy kind of thing, so that the needs of those specific people could get addressed, right? They are getting benefited from the policies of the government. But here there is an extreme dependence on the policy. If you are having one government who is giving one set of subsidy, there may be another government, it may remove or it may redefine subsidy kind of thing. So again, you will remain on the boundaries. Inclusive society basically ensures that all policies should be coherent in such a way that the needs of all people should get fulfilled. That means everybody should get the benefits of the healthcare system. And that is why the concept of universal health coverage is coming into picture. And when ma'am was talking about the three different models, the purpose was this, that a healthcare system should operate in such a way that the health needs of each and every individual should get fulfilled without compromising on the quality of life. And I'd like to talk about here one very important thing. You all might have heard of World Health Organization. World Health Organization, way back in 1978, the Alma Ata Declaration talked about health for all. Now, this principle, health for all, actually talks about developing a system in which the health needs of each and every segment of the society should get fulfilled. So that is the larger thing that we need to keep in mind. All basically the World Health Organization, or for that matter, the different systems of government in principle do talk about some kind of equality, but to what extent their policies are fulfilling this need and requirement is basically a question that we need to discuss. I hope I have explained the thing at the conceptual level also, and the question raised by the participant is, I hope, somehow answered. Is this okay?
Yes, sir. Thank you, sir.
Very good. I'm happy. Now, any other question? Meanwhile, Professor Miwako, we have already taken plenty of time from you. So I'm feeling so. I think that now you can leave this meeting because you are here for 3.5 hours continuously. So there is no more question from you. We will meet again tomorrow with Professor Miwako, and I would like to share with the participants here that tomorrow we have a small inaugural program also, right? So you will get an opportunity to listen to the university officials of Aligarh Muslim University, the Pro-Vice Chancellor, the Dean, the local coordinator, etc. And the participants and the foreign faculty will remain available online. Some of us would be there in a setting environment also, but the program is primarily online, and everything will operate like it is operating today. So with these words, I would like to say thank you very much to Professor Miwako Hosoda for a wonderful session and giving us wonderful insights on the Western model of basically healthcare, specifically UK, US, Japan, and we will learn a lot from you in the next days, in the forthcoming days. Thank you, Professor Miwako. You can leave at your...
Thank you very much. Thank you.
And I request the participant to remain engaged, because now we will have another important and very interesting component of this tutorial, right?
Yeah. See you tomorrow. Yeah, I'm looking forward to learning together with you. Thank you very much.
Right. Thank you. Now the participants are basically requested to make some kind of presentation and observation. Now this platform is open for all the participants. You raise your hand and give a summary of your learning today. Whatever you have learned, whatever questions are there in your mind, and whatever way the lectures have helped you to understand this say very important topic, which is not only academic but also related to our day-to-day personal and social life. I'm not getting responses from participants. You can unmute yourself and ask the question. See, that is the purpose. That is the purpose. If you are not asking the questions, if you are not expressing yourself, then this whole arrangement is basically not going to benefit you. If you are not fluent in your language, even then you can try to make us understand your question, because this is the platform which promotes two-way learning, right? This is better than the classroom platform on several accounts. Again, Aparna, are you there? Aparna, you have raised a question. Can you ask this question?
Sure, sir. So my question was, if through certain specific examples, if we could understand what's the difference between equality and equity with respect to the healthcare industry, or just even what happened during COVID. I mean, people in large numbers did not have access to healthcare, but at the same time, certain people who had certain privileges did get what was needed, but in large numbers, most people didn't have. So how do we apply sort of an equality or equity angle?
Right, that is a wonderful question. I wanted to listen some question like this. Now here, what is your background, Aparna? Can you tell us?
Yeah, so I've done my master's in gender studies from Tata Institute of Social Sciences. Presently pursuing my MPhil.
Good. And where you are doing your MPhil? That TIS itself?
No, BITS Goa.
Okay, very good, very good. Good question. Now, see, there are few questions that I would like to raise first, and then I would like to respond to. When we are talking about health or healthcare, then many friends or students coming from medical background often ask this question that health is a medical science related issue, right? So what are you social science people doing here? Then we need to understand. I used to respond to those people in a very systematic way. Basically, when you look at healthcare, then there are clinical dimensions related to health. Definitely, we all are aware of this. If somebody is sick, need of some kind of medical intervention, then certainly goes to a doctor, a hospital, and that is basically the clinical aspect of the healthcare. But at the same time, we have the preventive care, right? And although there is one very established stream of preventive medicine, sometimes people also talk about community medicine, and these branches of basically the modern allopathic system of medicine do talk about how can we prevent the occurrence of disease, and vaccination is a very important part of that. But we need to have a further layered understanding. How does it operate? During the COVID, we all got to know a lot about immunity and immune system. Basically, every individual has his or her own specific immune system, and medical interventions do take into consideration the kind of support that the individual is getting biologically from the immune system that he or she is having. Now, if you deconstruct the immune system, we find several important parameters. Nutrition is a very important parameter. If there is poor nutrition, then the individual will not have a very good quality immune system. That is an important variable or determinant of immune system. That is nutrition. Second thing, there are several other important components, like we have sanitation issue. Without sanitation, we cannot think of public health in a significant way. Because if there is a spread of malaria, then no matter what kind of immunity you are having as of now, if there is plenty of exposure to the vectors causing malaria, then your health condition will always remain vulnerable. Just like that, if there is an extreme prevalence of any other communicable disease, then the health of the individual will remain compromised. So for basically making an intervention on the spread of those communicable diseases, we need to make an improvement in the overall health environment, right? And sanitation does play a very important role here. We all would be familiar with the thing that diarrhea is still one of the largest killers in India. One of the major cause of infant mortality in India is diarrhea, something which appears to be so preventable. But why this is continuing to be the largest killer? Or tuberculosis, one of the biggest killers in India. So these are the problems which are not just are in need of clinical intervention, but these are also in need of some kind of social intervention in terms of public health. So we need good nutrition, we need good sanitation, we need good garbage disposal system, we need good quality of water. Diarrhea, one of the major cause of spread of diarrhea is basically a lack of potable water, safe drinking water. Who will ensure these things basically? A clinical practitioner is not going to ensure that in your family or in your locality, you will get good quality water, proper nutrition, good quality food, and most importantly, a very good quality of life in terms of maintaining fitness. Now, what is happening that the cardiac disease, the cardiothoracic diseases, basically heart attack, blood pressure, diabetes are increasing immensely because of the sedentary lifestyle that we are having. If someone is becoming sick, then this clinical system can operate. But the larger goal is not to get adversely affected by these diseases. That means we need to take care of the preventive system where we should not get exposed to these kind of problems. And here we need huge intervention in terms of policy making. So who will take care of the health policies? Who will take care of the health system? If the system is not supporting the individuals or the households or the communities, then people will get exposed to. So the third world countries or the developing countries, which are basically getting victimized because of the communicable disease, they are not becoming a victim of the individual disease causing vector alone. They are also becoming victim of the poor health system. And that is why we are talking about the health system. And who can study the health system? Definitely the social scientists can study the system very well, right? Everything depends upon funding and budgeting. Expenditure is a very important factor. In India, the high cost of health expenditure is one of the major cause of impoverishment, right? So who will take care of the financial part? Of course, the social scientists need to come forward, the economists need to come forward and talk about a viable model of healthcare, right? That means there are multiple dimensions involved. There are social dimensions, there are economic dimensions, there are political economic dimensions. Governance is a very important factor. You might have read Foucault, The Birth of the Clinic, right? Or you might have read several other sociologists who have contributed a lot to understand the health system. Health as an institution is operating in a specific way. Healthcare system as institutions operate in a specific way. The kind of relationship which is existing between the doctors and the patients, that is playing very important role. And here the term social capital is coming into picture. That is why we have fixed this topic, social capital and health, because health care system is not existing in isolation. It is existing in a society. It is getting influenced by the kind of value system which is existing in the society. In a society which is primarily discriminatory, the health system will also operate in a discriminatory way. How can we address the problems related to that? For that, we need to create an inclusive system, but you cannot have an inclusive institution or a system in a society which is largely exclusive or discriminatory. So for improving the functionality of those institutions, we need to make an improvement in the larger system, in the core value system, what our government, or basically what the Constitution of India is talking about, that we are a socialist, secular, democratic republic, right? So to the extent that those values are remaining only in the Constitution, our day-to-day life will not get affected. But when those values are getting actually infused in the system, getting translated through actions, then these will basically benefit people at large. And if we have this kind of large perspective, then we can see the individual situations. What happened during COVID? Of course, people who had some kind of savings with them, they managed them appropriately. But what happened to those people who were not left with any kind of saving, and all of a sudden there was a lockdown? There was a basic question of how to manage their livelihood, how to earn their basic livelihood. And when they are unable to basically maintain the livelihood that they are in need of, then how can they think of ensuring the kind of health requirements that COVID has necessitated at that point of time? And who will address these questions? Certainly, here the role of the social scientists or the students coming from social sciences becomes very important, because we can deconstruct the larger scenario by applying the social theories, of course, the political economic theories over there, and make or help the government in developing a better inclusive healthcare system. So that is, I think, my response to one very interesting question that Aparna, you had raised. I hope you got some insight, some idea. Is this okay?
Yes, sir. Absolutely. Thanks for answering my questions. Thank you.
Good, very good. Thank you. Any other question? Akhtar Hussain has raised a question. Sir, kindly reflect on these terms. Which terms, Akhtar, you are talking about? Akhtar, are you here? No, I'm not getting any reply from Akhtar. Any other question from any other participant?
So it was actually at the time when we were talking about equity, equality, and inclusiveness. At the time, I raised the issue to reflect on these things.
So is that question answered by now?
Yes, sir. That was answered very well, sir.
Good. Any other? We are having many students coming from engineering background. Can anybody unmute himself and share why do engineers want to understand these things? It will help me a lot. Nobody is responding? So what should we do now? Okay. I'm coming to the last component of the lecture.
Excuse me, sir.
Yes.
Sir, I have a question. Can you please differentiate between macro, meso, and micro level of society?
Who is asking this question?
Srija Nandi.
Okay, Srija, can you tell something about yourself? What are you doing as of now?
Now I am pursuing a master's in English literature from Aligarh Muslim University.
Okay, right. So macro, micro, and meso, right? Primarily, macro means when you take into consideration the larger system, right? For example, even when we talk about in health system in India, right? Then that is a macro perspective. So when economists look at the problems, generally they have a macro perspective because population in India, it needs a kind of macro level understanding. The infant mortality, right? Or child mortality, or income, or anything that basically for which you look at the larger picture, that is primarily the macro perspective. Pardon? At a larger level, and institutional level also. Now, the micro is something which goes to the individual units. When we look at the things at the level of the individuals, right? Or even within the individual, there can be several levels or layers of understanding, right? So this can be seen as a micro level. And a meso level is basically coming in between. Now it will depend upon which specific perspective basically you are taking into consideration. Because sometimes we also talk about family. Now whether family will come under the macro level or a micro level. So sometimes it will come under micro level, but in a specific disciplinary situation, it may come in between also, right? So economists have a different basically orientation. Now, sociologist is having a different orientation, and an anthropologist basically, very interestingly, will have altogether different orientation on this. But I think I have shared a brief understanding on this topic, right? Is there any other question linked to this question?
No, sir.
Yes. Dr. Swalehin is suggesting that meso level can operate at the community level or corporate level. Yes, basically it will depend upon the in-between situation. The micro and the macro are actually well defined. The meso is something in between that will depend upon the specific situation that you are talking about, kind of thing, right? Not in absolute terms. That is why I'm saying kind of things. It will depend upon the relative, basically positioning. And then Srija. Okay. Is there any other question remaining unaddressed? We have many faculty members here. Can any faculty member come forward and introduce himself, herself, and respond to the lectures today? I think people don't want to come forward and respond because participation level is very high. But responses are coming slow.
I joined class lately, so I did not listen fully.
Pardon?
I joined the meeting lately, sir, so I did not listen fully.
No, you need to join it simultaneously when we are basically holding these classes, because if you are unable to join the lectures, then you will not understand the things, right?
Okay, sir.
Any participant from Aligarh Muslim University?
Hello, very good afternoon, sir. This is Umar Khan from Department of Sociology, AMU.
Yeah.
First of all, thank you very much, sir, for organizing such a wonderful course and lecture. So my question is that when defining in lecture one, ma'am talk about social patterning of health. So at that time she talks about illness behavior. So my question is that how does the illness behavior is different from the sick role? And the second question is that, sir, when defining the Dahlgren and Whitehead model of determining health inequalities.
Umar, let me try to address the first question first,
okay,
and then we can take up the second question.
Okay, sir.
So primarily you are talking about illness and sickness, right? Or sick role. See, very often we talk about illness and sickness in a similar way. Often we think that illness and sickness are the same thing. Sometimes we also consider disease. Ill, sick, disease, all at similar level. But sociologically, basically we differentiate all these terms. Even psychology, or say in social sciences, we differentiate all these three terms, right? And it would be very interesting to understand the differences, because when you are talking about healthcare, then you need to understand where the person is actually socially situated. That is a very important part. Let me give you a practical example first, and then you will understand the difference between these concepts. Somebody is having, say, some kind of pain in his or her stomach. Say, a woman, right? 70 years old women, and then a child, 7-year-old child, and say a person, a man, 30-year-old man. All three are complaining that they are having some kind of pain in their stomach. What do you think, on the basis of your observations? Will the response coming from the family members will be same for all the three situations, or will be different?
Will be different, sir.
Will be different. What kind of difference you can observe?
Sir, in the care, the child who suffers the stomach pain gets more care as compared to the adult member of a family.
Okay, good answer. Now, suppose the timing of that complaint about pain in the stomach is the normal school going time of the child, right? Say when the child is getting ready for going to school, and all of a sudden he says that, oh, mom, I'm having some kind of pain in my stomach. I cannot go to school today. Now, will there be any difference in the understanding of the situation?
Yes, sir, there is a difference. Parent
What is
consider it
that?
as an excuse for not going to school.
Right, right. That means having the problem and talking about the problem, there may be differences, right? Right. So this is actually the reporting, the social reporting. Illness, sickness, and disease are examined in terms of the way the people basically complain about the problem and the way the society is responding to that complaints. Now, let me come to the concept. Disease is basically a biological situation, right? Biological situation means that if any of the organs of the body is malfunctioning, then one can say that the person is having kind of disease. But say if the person is healthy, if he is not having any kind of problem, but despite of that apparent healthiness of the person, there's a possibility that some of the organ or some of the functions of the body may have some kind of problem, right? So disease looks at the problem very objectively. Sometimes we do not know something, we are not aware of something, we are not having any problem as such, we do not have any complaint, but still the malfunctioning or the maladjustment may exist in the body, right? So that can be identified as a disease, which is an objective condition of the body. Illness is the self-realization of that problem. An individual is the first person who is having a realization of the problem that, okay, I am perhaps not okay. I am witnessing some kind of pain, or I have some kind of problem in walking, or I have some kind of problem in seeing something or whatsoever, or hearing something. The individual basically, or she is feeling lethargic. So the self-realization of the problem is illness. But when someone basically have this self-realization, it is not necessary that the society will accept that thing. Because as in the case of that child, the child said that I'm having some kind of stomach problem, but the mother didn't recognize that problem. This is also operating at a larger level, that people may have some kind of problem, health-related issue, but the society at large or the family may not respond to that. The family or maybe the doctor will not say that there is a problem. So social recognition of that health issue is again an important aspect of health. So when a problem, when a health-related issue gets a social recognition, then it is known as sickness, right? So illness is the self-realization of the problem, but that if someone is having a self-realization and reporting the matter to the doctor, and the doctor is recognizing that there is a problem, then no treatment could start. So illness is one stage. This illness needs to get converted into sickness. That means social recognition should come. The family may recognize, the community may recognize, the doctor may recognize, and that is basically what is sickness. So at one stage, someone may have some kind of disease. At the next stage, someone may have some kind of illness. And the third stage, someone may have some kind of sickness. When there is confirmation of the sickness status of a person, only then the health system basically operates. Now, what is the larger concern here? The larger concern here is this, that to trigger the healthcare system, the illness condition needs to get converted into sickness condition. Now, there are several social barriers. Poverty is one of the biggest such barrier, that sometimes because of poverty, the illness is not getting converted into sickness, right? Discrimination is a big barrier. Because of social discrimination, the condition of illness is not getting converted into the condition of sickness, right? Discrimination, gender discrimination. I talked about one woman of 70 years old. Even if a socially discriminated person is having some kind of problem, there is a possibility that the immediate environment may not recognize that problem as a problem, right? On the other hand, when an adult who is basically the earning member of the family, when he is making any complaint, then everybody becomes very equally concerned. Why? Because he's the earning member. That means his social positioning is playing a very important role. And this is how basically discrimination operates. Whether that is Indian society or a Western society, every society is having a kind of gendered kind of thing. Just like that, every society is having a kind of class discrimination, racial discrimination. And this social discrimination plays a very important role in deciding the health-related different stages of that individual. So that is briefly the answer of the first part of the question, Umar. Now, what is your second question? I hope you got some clarity on this.
Yes, sir, I got the clarity on it, and thank you very much for answering. And my second question also get answered in your explanation, sir, that I just wanted to understand that how does that Dahlgren and Whitehead model for determining health inequalities in a rainbow model of health, in the last circle, they talks about society and economy. So you explained it in a very well manner that how does it affect the health system.
Right. Now, let me add one thing. Talcott Parsons, a very important sociologist, he talked about sick role, right? And he said, basically, whatever I explained, that was based on Parsons' theory of sick role. He says that he has made a very important contribution here. Basically, we all need to understand this. We all need to understand. Parsons says that sickness is not something for which individual alone is responsible, or for that matter, individual is responsible, because this is a social causation. So illness is a pathological condition. This is not good for the society. And that means the society needs to make an intervention. And a person who is sick needs some kind of special care from the society. And not only a special care, but also some kind of relaxation in the responsibility. So when a student in a classroom says that, sir, I'm feeling sick, then all of a sudden the teacher becomes very liberal. Okay, you need some care. Some of the colleagues sitting around that person gives some kind of support kind of thing. Because sickness is not something for which the individual alone is responsible, or the individual is responsible, because somehow the immediate environment is responsible. According to Parsons, the social system is responsible for causation of this illness, and that is why the concept of sickness is very important, right? We are coming closer to end of the meeting. So any quick question? I can take up one last question.
Hello.
Yes.
Hello. Assalamu alaikum, sir.
Walaikum assalam. Who is speaking?
Sir, my name is Tehzeeb and I'm from Department of Sociology.
Yes, Tehzeeb, your question.
Sir, as you are talking about sickness, you said that sickness needs when a person is sick, he needs intervention and care. So basically, sir, I'm working on pregnancy and childbirth. So during pregnancy, also women needs care, and during their childbirth, she needs intervention in case of complication. So can we put pregnancy and childbirth as sickness? Can we put it in that category?
See, presenting pregnancy and childbirth under the category of sickness. Yeah, that is the question. Right. That's yeah. From that perspective, see, when I have written a book on sociology of health, I have dealt with this issue when we are talking about reproductive health here, because the topic that you are talking about is related to reproductive health. No, see, reproduction is a social role, but at the same time, it's a biological role. So long it engages the biological dimensions of life, it is exposed to the kind of needs and interventions which can make some kind of viable improvement there. So if you look at it from that point of view, then a woman in a pregnancy situation does need some kind of medical support, and we all know about antenatal care, postnatal care, etc. So if you look at it from that perspective, then definitely pregnancy is a special biological condition, and here you can look at it from the perspective of sick role. And just to explain my situation better, you may be aware of the thing that when a woman who is working in a formal sector, right, she is getting leave during the pregnancy period, right? And this provision of providing leave during the pregnancy period, which is a very ample amount of period is basically provided, that means that is coming at sick role category, right? Definitely. And a woman is supposed to provide basically the medical documents related to that also, right? So from that perspective, we can place that. However, there are arguments basically which say that this is a natural condition of life and we should not define this as a sick role. Yes, of course, that is also true that it is a natural condition of life, but not every individual is equally exposed to that. Not the males are getting exposed to that situation. It is only the female who is getting exposed to that kind of situation. That means it is a special social position, right? So that special social position does categorize it under sickness because it needs some kind of social support and some kind of social relaxation in the roles and the responsibilities during that period, right?
Yes. Yes, thank you, sir.
Yes. It engages lots of expectation and obligation of the affected person, and self-care is again a very important thing. See, this is a very important aspect. When you look at reproductive health related issues, or for that matter, health and gender related issues, then we cannot make such a broader statement. Basically, this is a very nuanced discussion. This primarily in this class, we are trying to discuss the issues for the public at large who are not having a very substantial understanding of sociology of health, or for that matter, these issues. So these are the nuanced portion. I'm giving you an overview, a lens to look at the things. But we may need to have hours of discussion on these topics. No more questions? So
thank you, sir.
Okay. So dear participants, I'm really very excited. We are excited at Department of Sociology. Our co-coordinator, Dr. Mohammad Swalehin Sahab, is here, and basically the chairperson, Department of Sociology, is equally concerned, right? So right from the foreign faculty sitting in Seisa University, Japan, to the host faculty, course coordinator, co-coordinator, chairperson sitting in Aligarh Muslim University, Department of Sociology, to people coming from GIAN office sitting at IIT Kharagpur, and of course the Ministry of Education, who has taken care of the logistic part of this arrangement. We all are basically very thrilled and have lots of expectation that participants scattered all over the country have joined this course, and we all have one single goal or target, that through this program, the knowledge level of the participants should improve. Their approach to look at the issues related to health system should improve, and we all should become a beneficiary of this very innovative program started by Government of India. So with these words, I'm coming to a closer of this class. Tomorrow, we have a very hectic schedule. I'm sharing with all the participants. We will have our class at 10 a.m., 10 to 12, normal class with Professor Miwako Hosoda on the topics already assigned. Then we will have a brief, basically, inaugural session over here, the Faculty of Social Sciences. That will be again a live telecast online. mode, and then we will have the tutorial sessions after that brief inaugural session. So remain excited, remain engaged, and enjoy these lectures. Thank you very much.